Good morning, everyone. How are you? It's a nice day today, nice sunny day here in Winnipeg. So welcome everyone to our, whether you're joining us in person, thank you for being here, or joining us on Zoom. Glad to have you here in our Learning for Life Health as a Human Right themed lecture series. My name is Tracy Bowman. I'm the Executive Director of Alumni Relations here at the University of Manitoba and a very proud UM alum. Before we begin, I'd like to acknowledge that the University of Manitoba campuses are located on the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories, we acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. So before I introduce today's speaker, all of you who are here in person, you know you've got your coffee, you've got your water, you know there's cookies afterwards, you know where the washrooms are. There will be time for questions afterwards. I unfortunately can't stay the whole time because I'm double booked at another meeting, but my wonderful colleagues Dustin and Lynn will have the microphones for you they'll be running around, so please do ask lots of questions. And also for our participants on Zoom, please also ask questions, and you can just post them right in the Zoom chat, right? That's the best place. And we will post them up, and then Dustin and Lynn can read them out, so that way we have lots of participation, lots of questions. I know Dr. Roos is good with lots of questions right at the end. So, all right, so on to the main event. I'm really delighted to introduce our speaker today, Dr. Noralou Roos. She is a professor emerita in the Community Health Sciences at the Rady Faculty of Health Sciences at the University of Manitoba. And she is also the founding director of the Manitoba Centre for Health Policy. She received funding from the Canada Foundation for Innovation to create Canada's first data laboratory containing population-based data on health, education, and social services, and has held a Tier 1 Canada Research Chair. Citations of her work place her among the top 100 Canadian scientists, according to the Institute of Scientific Information. She was also a member of the Prime Minister's National Forum on Health and the Interim Governing Council, setting up the Canadian Institutes for Health Research. She's also received the Order of Canada, and she's got her pin with her today. And she was an elected member of the Academy of Sciences of the Royal Society of Canada and Canadian Academy of Health Sciences. She's worked with Health Canada and many groups across the country to fund and implement a research network to monitor post-market drug safety and effectiveness. And she's also, if you're noticing the Winnipeg Foundation logo on her slide, she is the co-director of the Winnipeg Foundation-supported GetYourBenefits project, which she'll be sharing with us today, to work with healthcare providers and community groups to ensure that poverty is diagnosed and treated by helping people access the benefits for which they are able. So that's a long list. So you know you are getting the very best on this particular topic. So with that, over to you, Dr. Roos.
Thank you. It's a real pleasure to be here today, I must say, for a couple of reasons. One, will be presenting what I spent a good part of my career doing research on, which was the impact of poverty on health and educational outcomes. But also what we are doing, as she was mentioning, trying to help people access benefits to overcome some of these poverty conditions. However, reading in the Free Press today, I was somewhat amused about Elton John, who, after doing his absolute last tour, spent time outside Saks Fifth Avenue in New York City doing a 15-minute, although apparently it went on to 17-minute presentation. They put a lot of money into a fund, but I was feeling today when she was going over all of these things that have been involved. I am now a professor emerita, and preparing for this lecture was very challenging because I'm always nervous when presenting to people, and yet it's been such a long time, and I actually put on my coat and I have my shoes that I haven't worn for probably 3 years. And so it's quite an occasion. So thank you very much for being here with us. So if I can operate this part, this is one of the most compelling messages, I think, that in this whole talk today, because I'm not a physician. Sharon McDonald, who works with me on the Get Your Benefits project, is, but I've spent my whole career at the U of M in the medical faculty. And the Canadian Medical Association, which is the organization for which all physicians are part of, several years ago put out this graph which says basically what makes people sick. And they then go on to itemize, and this is based on their review of the evidence, the data, et cetera. And they note that 50% of what influences our health is our life. And right up there at the top is poverty and aspects of our life that is very different from what we think about when we hear about the disaster that our healthcare system is in and what do we need to do about it. And usually the thing is that, well, we need to build more beds or we need to build more oomph. What the Canadian Medical Association is saying is that is not necessarily where our total focus needs to be, and that is part of what I will be talking about today. So part, of course, is biology, genetics, our environment. There are all sorts of things which contribute to health. But life and what people are exposed to, what they experience, et cetera, is a very big part of it. This is a summary which I was not part of producing, but because it's so graphic in what they point out, I do like to include it. And this is a group that has, again, compared the data and goes over a whole series of things which compares the most affluent 20% of Canadians with the least affluent 20%. And in terms of health, they are very different. And the least affluent have higher rates of diabetes and heart disease, arthritis, 3 times the rate of bronchitis, hugely more disability, serious disability, mental, behavioral disorders, ulcers, you name it. And that's what is experienced by the poorest proportion of the population. So what about Manitoba? Well, these data actually come from an article that was in the Free Press several years ago, where they looked at life expectancy. How many years are you expected to live, i.e. length of life, depending upon what part of Winnipeg you live in. So again, they used census data, they used very accurate data to understand, and they adjusted for the mix of people who were there. So it's not just that they had young people in one area, old people. This was all adjusted for. And they find this remarkably huge difference where in the inner city, people are expected to live 66.7 years, whereas in the more affluent suburbs, people live 80 years and longer. And you'll note it varies. Where's the highest? 84.5. I don't even know how to label that, but it is depending upon the affluence of the area in which you live. That means people who are more affluent live there. It's not necessarily the environment that is affluent, it's the people who are affluent. Makes a huge difference in terms of life expectancy. So, I wanted to give you some background on where the data which I will be presenting comes from. And as was mentioned, I was the founding director of Manitoba Centre for Health Policy with my husband, Les Roos. And I can't tell you how, or I want to tell you how great a resource this is for the University of Manitoba. They have created a research potential here that is frankly nowhere else in Canada and very few places in the world have the capability of doing this research on the entire population of Manitoba going back 50 years. As an indication of this, people working with MCH data this year brought in over $21 million in research funding to the U of M. So it is a broadly used resource, and I'll give you some idea of why. When my husband and I first came to Manitoba, which was, I have to tell you, I came kicking and screaming. I was born in California, went to school there, raised lots of issues. I remember the first time I ever saw snow in California. It was just remarkable to me. And my father had been brought up in Minnesota, and I could remember him talking about walking to school in the snow and what a disastrous experience it was. And when my husband decided that he was ready to move, and Manitoba came up actually with 2 jobs, which was for, at that point in time, this was the early 1970s, was a very difficult thing to acquire. I finally said, well, okay. So we moved up here in, I think it was December 72. What? And it's been a marvelous experience. I love Manitoba. We've obviously stayed here, and working on this research repository was a very big part of it. As a researcher, it was incredibly challenging. Because what it consists of, what it means is, we figured out every time you go into a doctor's office, or every time you are admitted to hospital, a record is created. It has your individual characteristics, age, etc., where you live, as well as diagnoses, what's happened, etc. And we started working with the physician who was head of the Manitoba Health Research, MHSC, whatever that was spelled out at the time, and said, you know, we could do incredible research with these data. How do we access them? And he said, well, so we started, a kid had died after tonsillectomy. And they were interested in trying to understand why. And so we started out working with data on kids, looked at that, went on and on and on and on. If you look at these data, it's not just that they have hospital and physician, nursing home, home care, et cetera, not just health data. We also, because it became obvious that there were many other aspects that were going to be related to health. So education data, social insurance data, income assistance, family services, et cetera, have been added to this database since over the sort of last several decades. And I was once on and I want to assure you, there are no names, there are no individual addresses, they're just forward sortation area addresses, which is how you link to the income data. And the center works very closely with the Privacy Commission to make sure that what it is doing is respectful of all the major issues that people have around using data like this. I remember at one point when I was presenting to the ethics committee at the university, a woman, community woman who was on this committee said, "But I don't want you knowing that I had gallbladder surgery." And I said, "I can assure you, we don't know that. You know, it's all done in a de-identified way, but what we're able to then look at is why do people have accidents? Why do people have complications? What are the predictors?" And we can work with physicians, blah, 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 blah. So, what do we learn from these data? Well, we were showing the very big difference in mortality rates, life expectancy between the poor areas and the affluent areas. And when I first started presenting these data, people would come up to me and say, "Well, that's not really a surprise. We know, I mean, you read in the Free Press every day that somebody in the inner city is getting shot, that people die from accidents, that there are overdoses, that there are HIV rates, that, you know, that there are real issues as to people who live in poor areas have around this." So we looked at, excuse me, what are people dying of? The 20% of those living in the poorest areas who had a life expectancy of only 67 years in this case, compared with those living in the affluent areas who had a life expectancy of 84 to 85 years. And if we look at these highlighted areas, those up there is a slightly higher percentage of infectious diseases, HIV, homicides, accidents in those low-income areas compared with the high-income areas. But what do most of the people die from? They die from, can I highlight? No, I can't. Those big black areas at the top are neoplasms. That's both in the low-income areas and the high-income areas. Most people die of cancer. Circulatory, again, very large in both areas, and other large in both areas. So the types of death are very similar, and in fact, even though it looks like there are somewhat lower, well, there's a lower percentage of neoplasms in the low-income communities because they have a higher mortality rate in any given year. There are many more deaths from cancer among low-income people than among high-income, looking at that 20%. So in terms of what people are dying from, we can't attribute it to shootings, fortunately. Another question which comes into when one is working in this area is, well, are they doing poorly because they have lousy access to medical care? And the answer is no. The Canadian system actually works remarkably well in terms of providing access to those who need it. These are rates of inpatient hospitalization rate. And we've divided, here we're not just looking at the lowest 20% and the highest 20%. We've divided into urban versus rural because they're quite different patterns of hospital use in rural and urban areas. And urban is Brandon and Winnipeg. And if you note, the bars at the top of each slide is the hospitalization rate for the lowest income group, and it is remarkably higher than the hospitalization rate for the highest income group. No surprise, they're sicker, the system's working. We also looked at physician contact rate. And while it's not as dramatic, and there are, I frankly did some research suggesting there are some issues around physician contact rates, i.e., one would like to see low-income people who have such health problems having more use than they do currently, but their use is now higher than highest income people. So that also is working not badly, I would say. So having sort of looked at this relationship between poverty and poor health, one of the things which we're frequently asked is, does increasing the income of low-income people improve health outcomes? Does it help? Healthy baby benefit was introduced in Manitoba, 20-some years ago, early 2000s. This benefit starts in the second trimester of pregnancy, if the physician assures the government that the woman is pregnant, has to file something. She starts receiving $81.41 a month while she's pregnant. And we were able to look at those women who had received the benefit compared with those women who didn't receive the benefit, again, controlling for all sorts of other things that were important to look at. And we found, yes, having this $80 a month meant that there was a reduced rate of low birth weight children, reduced rate of preterm, that's earlier than 9 months, what the expected rate was, and reduced the small for gestational age. So again, that's another version of sort of low birth weight. Those are the three major measures of healthiness among children who are born. So, this was an interesting demonstration of why income is important. As I mentioned, we didn't just focus on health outcomes using the center data. We were also able to look at educational achievement and how it is related to socioeconomic status, SES, as some people say. First of all, just look at, on the left, it's my right. look at the left-hand side, because that's what we looked at first. We were focusing on the language arts exam, which everybody in grade 12 in Manitoba is expected to take. And they use this for assessing all sorts of things. And we had the results, so we started looking at this. And we were looking at it according to the income, the low versus high income areas in which children lived, not the schools, but where the kids lived. So just as we were looking with health status, we're looking now, although it's not 20%, it's the 25%, lowest 25%. And as you see, the rate of passing the language art test varied from 70% to 94%. So, as with health status, there clearly is a strong relationship between educational achievement and socioeconomic status. But when we looked at this, we realized that this is one way of looking at these data, but because we had this rich database, there were other things that we might look at, and we started talking with the educational people about what other aspects would be interesting. And because we started out knowing that we know kids who should be in school because they are 17 or 18, and they live in Manitoba, they haven't left Manitoba, but they're not in school, they're not enrolled in school. So we started adding them to the group, and that's that big black bar at the top for the lowest income. There are also several others groups that they were held back so that they hadn't made it yet to grade 12. That's the gray group. And then there were those who were in school but who didn't write the test, and a variety of other things. So the real data on education, the relationship between education outcomes and poverty or socioeconomic status, is the bar on the right. They're just the same kids in this set of graphs are in that set of graphs at the red and green level. But as you can see, the real comparison between those who passed the standards, language arts standards test, is not 70% to 94%, it's 24% to, I can't read that, 86%. Yes, 86%. Which is pretty disturbing. So another important educational outcome that we looked at was graduation rate. So of those students who entered grade 9, we gave them 6 years. So if they were held back, et cetera, we would still count that as successful graduation. And we again compared where does the student live. And we ranked areas by basically affluence of the people living in the area. And in the highest income areas, which are River East North and Assiniboine South, the green areas up there at the top, almost all the students who entered grade 9 went on to graduate. But in Point Douglas South and Downtown East, which are the two areas at the bottom of the graph, only 50 to 66% of their students entering grade 9 graduated within 6 years. So again, a dramatic difference. But some interesting good news, we updated as sort of part of preparing this talk. I said, I had some old data that on this, and I wanted to know, has anything changed? And we didn't want to include the COVID years because we knew everything got screwed up with the COVID years. So we looked at the 4 years. This is based on the years before COVID. But my previous graph, which went back about 10 years from this, showed that the graduation rates of the lowest income areas have increased pretty significantly. Before they were below 40%, and now they are at least above that. So that was encouraging. One can't talk about poor health associated with socioeconomic status and educational outcomes without understanding the major issues which First Nations, Indigenous people face along that dimension, poverty dimension, life-challenging dimension. And Manitoba Centre for Health Policy has worked closely with First Nations groups to analyze their things that they're interested in. And we produced a First Nations health report, which has been many years ago, which has been widely used and cited. And these were some figures that I came across recently, which showed child poverty rates in status First Nations on reserve. That's the high, that's the 53%. Then the off reserve, 41%. The other Inuit, Métis, non-status First Nations are all, again, much higher than that 12% of the non-immigrant, non-Indigenous rest of us Manitobans. So that is another aspect of this that one has to be very aware of. And what's been happening in terms of this income inequality issue over the last several decades? And the answer is nothing that looks very good. This came out of a United Way report. They were part of it a few years ago, showing how income inequality in Manitoba has been increasing dramatically over this period, going back to 1989 to the most recent data is 2017. So over that period, the wealthiest group in Manitoba has seen their income increase dramatically, whereas the average income and certainly the lowest income has increased very little at all. So nothing is improving. And now we get to what I'm currently most passionate about, our Get Your Benefits project. And this all started with the Winnipeg Foundation when Sharon McDonald and I actually had lunch with the no longer head of the Winnipeg Foundation. And he asked us, he said, do you think there's really a problem of income inequality in Winnipeg? And we said, Richard, you've got to be kidding. Yes, there's a very, very big problem. So what we're trying to do is to, I mean, we're basically sort of academic. She's a physician, I'm basically an academic. We're trying to put evidence out there as to what is the impact of poverty and to communicate how this poverty can be addressed and should be addressed. And then we make connections across organizations, across ministries, et cetera. That's really what we're involved with. And this is how we started, that we wanted physicians to diagnose and treat poverty. Don't worry, don't just ask about, have you had your vaccinations, you know, do you have allergies? Ask, do you have problems making ends meet at the end of the month? And if so, how do you connect them to benefits that they may be eligible for? And ask, you know, this, have you filed your taxes? Which sounds crazy, right? But this whole project, in fact, was a big influence by Dr. Gary Block. He's a Toronto physician who heads an inner city health clinic. And he had an op-ed, opinion editorial in the Globe and Mail, which said, this time of year, I prescribe filing taxes to my patients. And then went on to explain why, which I thought, how bizarre, but the explanation was interesting. And when my daughter left home, went to college, she decided I needed to have some continuing sort of relationship. I assume that's not mine, no. So I joined the big sister, big brother sort of operation, and I had a young brother that was, I was big sister to a young man who had the CIBC fellowship his last year in high school, and they helped him get a job at the YMCA, or YWCA, I'm not sure which, weekends and a couple of days during the week and a month during the summer to earn some money before he went to university to help with some of the expenses. And after I saw this filing taxes thing, I said, did you file your taxes last year? And he looked at me like I was out of my mind. And he said, Noralou, I can barely afford a cup of coffee. I'm not going to give the government my money. I said, no. Every time you get a check, they're withholding money from your check. And if your income goes above a certain level, they'll keep that money. But if it doesn't, they'll send it back to you when you file taxes. So he finally was persuaded, filed his taxes, and he got several $100s back. And he was just overwhelmed. And that's when I began to believe there's something here that we need to communicate about people accessing your benefits. So why this outlines how you do it, what's important. The numbers are incredibly impressive. These community volunteer income tax program runs across the country, but this is just for Manitoba. You can only access this program if you have a low income, sort of family income of around $30,000, $35,000. They'll help you file your taxes for free. In 1 year, they bought back to the 29,000 Manitobans filing their taxes $102 million. Okay? this is a significant way of people accessing benefits. This is just an example of your low-income woman who might be working part-time, earns $15,000, and goes on her business. That's all she would have. But if she files taxes, and you'll note the whole series of benefits, the Canada Child Benefit, the Canada Worker Benefit, whole series of both provincial and federal benefits, her annual income would go up to $38,000. Seems impressive. It's not just young women with kids who benefit from filing taxes. This is an elderly lady who has a part-time job, survivor pension, $7,800. If she files her taxes, she brings her income up to $19,000. And again, this is simply, people don't understand that, and I keep saying, for God's sakes, how do we communicate that filing taxes is a good thing to at least some people, not necessarily all of us, but to many people? And it's a very difficult thing to do. There are other areas that we've been working on to try and help people understand benefits that they're eligible for, that they're not accessing. And one is this Canada Learning Bond. I'd never heard of it. Had heard of the RESP, Registered Educational Savings Plan, which my grandkids are all part of, and it's important. But the Canada Learning Bond is for low-income kids. You have to have a family income under, if you have 1 to 3 children, under $48,000 or less. You're eligible for up to $2,000. This is a kid, up to $2,000 that the federal government will deposit into a savings account, which you can access if you graduate high school. You can use that for any post-secondary education. Beauty school, plumbing, whatever. And the money can stay in the account until the child is 35 years old, so it doesn't have to be immediately used. But how do we do in terms of take-up of this incredibly useful benefit in Manitoba? Well, there were 65,000 Manitobans in 2021 who received the Canada Child Benefit. And these 65,000 people received $62 million. Okay? So non-trivial, but the number of people eligible in Manitoba for this $2,000 was 204,000. So a lousy take-up rate, 32%. And other provinces, nobody's perfect on this, but other provinces, Quebec is up to almost 50%, BC is 50.9%. So again, why is Manitoba not doing better on this? I mean, this is free money. You don't have to put any money as a family into this to get this $2,000. And it's a benefit which we're trying to figure out how to connect people to. This is another benefit which I just heard about 2 months ago when, again, I said we do connections. I was on a phone line to somebody in New Brunswick And I get a call afterwards from somebody in the federal government who said, wondered if our project might be interested in helping them access people with serious disabilities who qualify for this disability tax credit, which is a pain in the rear to qualify for. I mean, it's not easy. Everybody you talk to mentions this. But if you qualify, you are then, the federal government will deposit up to $1,000 a year for 20 years. That's $20,000. And if the family puts in money, they don't have to, but if the family does, the federal government will match it $3 to $1 because they're trying to enable these families who have people with serious disabilities to think about sort of the future when the parents are no longer there to provide support, et cetera. We've been trying to figure out, okay, how many people are accessing these benefits. We know, first of all, that a lot of people don't access, even though they should be able to, or not getting the disability tax credit. So that's a whole nother story. But of those who have the disability tax credit, so they are clearly qualified, our estimate, and this is not easy to do, we're working with the federal government to try and get this precise, but it's something like 32,000 people are likely not accessing this $20,000. And these are people with very serious problems. Another, and this is a very different kind of benefit, but free books. Somebody told us some time ago, which I find hard to believe, given our grandchildren, et cetera, that 25% of Canadian households don't own a single book. First Book Canada works with book companies that have too many books, haven't sold all their books. They give away free books. All you have to do is testify that, or sign something, it takes 20 minutes to sign up, that you work with an organization that provides people that works with an organization that serves low-income people. You don't have to provide any data, you just have to testify that you do. And they come out once a year with huge truckloads of books. And I've gone twice to see, are these reasonable books? You know, because people have said, well, I don't want to just be forced book. These are good books. And Seven Oaks, when we first were starting, they were one of the first groups to work with it. They got over 700 free books delivered to them by this organization. This is what we've put together for the trying to summarize for people, how do you get your benefits? And if anybody's interested in one, you're welcome to take it. We encourage people to access it online, to order it. We've thus far delivered about 160,000 of these booklets to people across the province. And my almost final slide is this, which I always find a little depressing, but it's sort of who's responsible for the poor outcomes that people living in poverty experience? Is it the parents who aren't providing the books, or society? And you'll guess my conclusion. So as my final thing, can you help? We're always looking for advice, suggestions, etc., as to how we can keep expanding this Get Your Benefits project. So if you know organizations that might be interested, we'd like to know about it. Schools who might host something for Canada Learning Bond. I mean, we know the ones we're working with, but there are tons we aren't working with, etc. So I put Eileen's email here. I'm the same, Noralou Roos at umanitoba.ca. Would love to hear from you with any suggestions, etc. Thank you very much. Okay, here's a question. Oh, you can read it. How would you apply for the benefits for low-income families? In terms of books for low-income families. Yes, you can. We've been working with some of the schools outside. Eileen actually lives outside Winnipeg, so she's been working with local schools. You would likely have to come into Winnipeg to pick up the books, or they have a very low mailing possibility. The books are free, but you have to cover mailing. So yes, and send Eileen a note, and she can provide you with details on that. That's just in Winnipeg. That's all over Manitoba. I think that's the same thing. Any other questions? How would you access the Canada Learning Bond for low-income families as well? That is a very important question. Again, there are a lot of details. Go on our Get Your Benefits website, and it will provide you with some of the details. Basically, you have to have a social insurance number, you have to file your taxes, and you have to fill out all the forms. And we try and run some super clinics, they're called, where families are encouraged to come in. And if you'd like to know about when super clinics are going to be held, that we can sort of put you in touch with. If you would like to organize a super clinic where, because Service Canada and the CRA are willing, they have outreach officers who will come out and work with at like a community club or a school, if you're will advertise to bring families in to sign up for these things. So yes, let us know what you're interested in, what you could connect us to, and that would work very much.
I guess I'm always very interested to find out all the information that we've been presented with, but how do the general population find out all this information? Is it done through social systems? Is it done through doctors? Is it done through hospitals? Is there a system set up to give that information to people?
That's I had never heard of this disability ever. And in fact, I've talked to people who work in this area who'd never heard of this. And to give them credit, the federal government now has these offices that are really trying to figure out how do we make this more understood and available, and they've been very responsive to anybody we put them in touch with, they meet with. But I don't know. I mean, for me, pushing things like automatic tax filing, so, and that would be incredibly politically difficult probably to introduce, but for anybody earning under $50,000 to automatically get that money back would seem obvious. And that's one of the things we've been pushing, is to try and get make some of these things easier. Same thing with the Canada Learning Bond. Why not make it, if you're eligible, because they now send out letters to families naming that child and telling them that you're available, but there's then a very long list of things that you have to do. And I don't know about you, but I get so many calls on the phone and emails and occasional hard copies of things, which you assume is crap, that you just, or that it's something you shouldn't respond to because it's likely going to invade your computer and take it over. So I think we do have problems communicating now as to when something may be good for you.
I'm a retired public health nurse, and this jumps right out at me, and I'm hoping that they are part of, because they have first entry usually after a child is born, and continue to be involved with the family. I hope they are a part of this or understand some of these issues.
I would love to interact with you as to what your suggestions would be and who you would suggest working with. We work with all the access centers that are in touch with people, so that is one way we do things. We present to medical students. We are working with faculty of nursing but they're so totally overwhelmed now that that's hard. But absolutely, I mean, if you have specific suggestions, people, organizations, let us know, because that's what we find. We're then able to sort of take the next steps, provide the information, et cetera. But thank you, that's, you're right, they are key. Thank you.
Okay, I would like to thank you all for joining us today for today's engaging presentation. Please join us on December 1st for our next session with Dr. Robert Mitzi, and have a wonderful rest of your day. Welcome back, and please join us for coffee, tea, and cookies in the foyer.